Thank you so much for the opportunity again to present. Yes. So, intraoperative fluorescein angiography in delayed postoperative vitreous cavity hemorrhage, POVCH. It is dispersed VCH post-vitrectomy for diabetic retinopathy, vein occlusions, or vasculitic vitreous hemorrhage. In the early immediate post-op, like in this case, it could be due to post-op clot dissolution or oozing stumps. But when it presents later, 6 to 8 weeks post-op, then it could be because of progressive neovascularization, traction, or anterior hyaloidal proliferation. In this case, it was mild, so it could be observed. However, when it is dense and persistent, it is necessary to do a vitreous lavage, which includes endolaser, retrolentil blood clearing, base shaving, cryo to the sclerotomy ports, and silicone oil or gas tamponade. All these steps, however, are left to surgeon discretion. When we do too much, it could be an over treatment, and when we do just a fluid air exchange, it could be under treatment. So we wondered if we can do as much as necessary with as little as possible, like the Goldilocks rule. We wondered if IOFA could enable tailor-made treatment and avoid under or over treatment. Eyes with dense POVCH post vitrectomy for PDR or RVO were included with a minimum follow-up of 6 months. This is the accessory light holder in the Constellation Vision system, and we fitted a blue filter of 14 mm diameter into it. So this is the technique of IOFA. We injected 2 ml of sodium fluorescein intravenously, and you can see the arterial and the venous filling times in this patient who is undergoing a vitreous lavage post PDR. So here you can see in the mid to late phases of the angiogram that this very well delineated capillary non-perfusion areas are there here, and this is even an IOFA enabled endolaser. This is the characteristics of the purely digital barrier filter by adjusting the color, hue, saturation, and brightness. So on IOFA, we could find the arterial and venous filling times, active NVE, peripheral leakage near the aura and the sclerotomy ports, and some novel findings as well. We had about 14 eyes with a mean age of 60 who had undergone vitrectomy, and we followed them up for 6 months. They bled about 75 days post vitrectomy. So this is a 69-year-old lady, known hypertensive and diabetic, operated for vitreous hemorrhage 2 years prior, who had a sudden rebleed. You can see the extensive CNP areas all over, and you can see delay in the venous filling. This is an IOFA-enabled endolaser. Now, if you look at the pictorial representation, this is the extent of the CNP areas we found on the IOFA. And you can see that there is only a central island of perfused retina. And you can even see the delay in the filling of this particular vein. This is a 55-year-old gentleman who had undergone vitrectomy for a BRVO. These are the CNP areas much beyond and posterior to the previous endolaser marks. This is an interesting case of a 68-year-old lady who had undergone vitrectomy with a well-lasered PDR. However, we found diffuse peripheral leakage near the aura in this case, and cryo was done to the ports, considering that this is an anterior hyaloidal fibrovascular proliferation. This is the last case showing that in the early AV phases itself, there were a lot of window defects at the posterior pole, suggesting an outer retinal and RPE atrophy in this well-lasered PDR undergoing a lavage for VCH. This was a unique finding we found in our series. This is an intraoperative screen grab showing that this is unremarkable clinically. However, on the FA, there were large window defects. In literature, we have seen IOFA being used especially for CNVM, and the pictures that we have in the literature are very small field, and they are quite not that high on clarity or resolution. Our study used a purely digital barrier filter, whereas in literature, barrier filters had to be placed in the operating microscope and moved in and out. And we saw a lot of biomarkers for vitreous lavage on this digital assisted vision system, high resolution and pan-retinal fluorescein angiography intraoperatively. This can unearth novel biomarkers in patients undergoing a vitreous lavage and can give predictable results post-vitrectomy for diabetes and retinal vein occlusions. It can potentially reduce the risk of recurrences, reduce over-treatment or under-treatment by allowing only IOFA-enabled treatment during a lavage. Larger studies are needed to determine its true efficacy in vitreous cavity lavage. Thank you.
Thank you, Dr. Apoorva.